Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co-host, Jocelyn Turner. It is a gorgeous day here in Northeast Florida. I don't know where you are, but I hope that your day was as fantastic as mine was here. Last week, if you were not on, if you didn't know it, we celebrated our 200th episode. Dr. Ken, I can't believe it that we have done 200 episodes. Can you believe it?
Why, you don't think you're that old? Yes, I can. Yeah, I believe that we did that long. Good evening, everybody. And I'm loving the weather as well, sister. It's just a great day to be in North Florida. I don't know what it's like anywhere else, but the skies were fairly clear. The temperature was not that hot. Um, I didn't even feel it when I got in my car today, so that means it was okay. And this morning, I had to second guess myself. Did I need a windbreaker?
Yeah, I thought because when I went to anyway, enough about the weather because we're certainly not meteorologists, but what we are, who we are the co-hosts of Pause for the Truth. Again, if you tuned in last week, you heard about our history, how we got started. We started during the pandemic and decided to keep it going because there's just so much information that we feel the community needs in order to have better health, more informed, to make more informed decisions about their health, so on and so forth, including their risk factors for different diseases.
Yeah, we had a little hiccup last week, but we're going to do another live, and I think we have it wrapped up at that time. So.
Thank you, Dr. King. I don't know where that static is coming from, but anyway, so joining us this evening as we have a conversation on breast cancer in Black women are one of our favorite past co-hosts, Dr. Kenneth Jones. How are you doing this evening, Dr. Jones?
I'm well, thank you very much. Enjoying a wonderful day in Jacksonville.
Absolutely, and thank you for joining us this evening. We missed you last week, Dr. Jones. I was just teasing with him that we're used to him being a pitch-in, a fill-in for Dr. Kane, so that's all right. We'll keep him in mind for future podcasts. Also joining us this evening is Diane Townsend from the Sisters Network of Northeast Florida. Diane, I'm going to start with you just real quickly. Tell our audience a little bit about the Sisters Network.
Absolutely.
Is it a local or national organization?
So Sisters Network Northeast Florida is actually a chapter of a national organization, Sisters Network, which is headquartered in Houston, Texas. There are about 25 chapters around the country, and in the state of Florida, there are 3 chapters. The Northeast Florida chapter that serves Jacksonville and the surrounding areas has been active in this community for over 28 years. And so our primary purpose when we organized was to support African-American women who've been diagnosed with breast cancer. When I was diagnosed, which was a lot of years ago, I remember that there was no one that I could go to that looked like me, that was my age, that had my background. So I just didn't feel the hope and the encouragement. So when I met the president of the national organization in Houston, she encouraged me to come back to Jacksonville to start this organization. And I found 4 other like-minded women, and we actually got the organization started. And again, our primary purpose at the time was to find local women who felt like we did, needing the support and the encouragement of someone who'd been diagnosed so that we could help each other along and care for each other. But we've expanded quite a bit in the years. We are now very active in the community, raising awareness, doing workshops, doing walks. We provide patient care kits in the community, and we provide speakers who are willing to talk about their stories and just to uplift people and to let them know that we are present in the community. And so when you need someone outside of your doctor and your techs and the scientific part of your diagnosis, we're there for that.
Thank you,
Also,
Diana. We'll learn some more.
The annual conference that you've been holding for many years. Locally.
Yes, Dr. Jones likes to talk about that because I have to let the community know that the very first annual symposium that our chapter held was in 1999. And Dr. Jones was one of our first speakers, and he has been active with this chapter. And I don't mean come and go active. Dr. Jones has really been active. I've been able to call on Dr. Jones at the last minute, and he's shown his support by being there for us. He's guided us with information and made connections in the community, helped us to network. And so we have been successful in probably holding annual symposiums. And when we've not been able to do a large event as a symposium, we've always been able to do a smaller workshop each year, except during the COVID community shutdown, of course. But each year we've been able to do that and bring to the community a free event, totally free event that brings all of the most recent information on breast health and breast cancer to the community.
Thank you. And Dr. Jones, why is it important that we specifically talk about breast cancer in Black women?
Well, the importance is that of the years that I've been in practice, which is over 44 years, I have seen so many younger African-American women develop breast cancer. And even though our incidence in the overall picture is a bit lower, our mortality rate is higher. So the question that I've always asked, is it because African-American women are not being exposed to diagnostic tests, surveillance, or is there something in the genetics of the tumor that African-American women have that makes our women more susceptible to dying when they develop breast cancer? So there's that continuum, and it continues because my goal is to get more African-American women participating in breast cancer research, either by just donating tissue or looking at lifestyles. There's so many things going on, but the concern I have is the fact that when our ladies get breast cancer, they die at a higher rate. And that goes across, including women. If you compare African-American women with the same economics as Caucasian women, when African-American women get breast cancer, they die at an earlier age.
Yeah, I've heard that before. So what are the most common warning signs or symptoms women should never ignore, Dr. Jones?
Well, what I'm hoping is that we don't wait for the symptoms, that we're getting annual mammograms. There's data to show that every African-American woman from the age of 25 should get breast cancer risk assessment. And there are a number of things available for that. But what's important is doing a risk assessment that's consistent with African-American women. And we have one. It's called the Black Women's Health Study Breast Cancer Risk Assessment. or risk calculator, and you could go online and find it. It is in more detail. And what we found is that it's very specific for ladies under the age of 40. Where if you were to take the standard risk assessment, the Gale or some of the other models, it doesn't make a difference when you compare it to African Americans, Caucasian Americans, Hispanic Americans. However, it's very more concentrated and more specific in identifying African Americans under the age of 40. So the ladies under the age of 40, if they have a high risk score, we have to be very aggressive in making sure they start their mammograms. They get MRIs of the breast. We have to be more aggressive. Now, we've heard about buddy check, but what I would like to say is that by the time you palpate a breast mass, it's been there for 4 or 5 years sometimes. So getting a mammogram is so important. And by that, I mean, get a diagnostic mammogram. Okay? The tomosynthesis. Get that at least the baseline. There are more specific tests you can do, but I think it's important that we stress upon our sisters that they must get their mammograms. And if you feel something, unfortunately, don't say, "Oh, that will go away." Or if I don't think about it, well, it's going to be gone. Or I'm not taking that disease. No, that's not what we want. Because early identification, early treatment, better outcome.
And Dr. Jones, I know a lot of ladies talk about, as you just mentioned, really, I think I always stress to people to know your breasts. But when I've heard different women say that one of their breasts is much larger than the other, and that gave pause for concern. Is that normal? Is that a risk factor for breast?
That's normal. No, that's completely normal.
Oh, okay.
Very few people are exactly the same size on both sides.
Okay.
And the other thing that a lot of African American women worry about is, my God, if I have one of my breasts off, what's going to happen to me? But that's where I send them to ladies who are part of the Sisters Network. I say, go speak to a sister who has gone through this.
Yeah.
She can tell you what the outcome is like. She can tell you all the side effects, which is something you can't. That conversation, even though the doctor will sit down and say, "Oh, I'm going to give you some medicine that's going to give you these side effects," go speak to somebody who took that medicine. They will give you the insight as to what it really feels like. And that is so important. That's why I've historically always supported and stayed a part of Sisters Network, because I send a lot of my patients to them.
He does.
The one thing that I will say, Ken, this time, but I want to make sure the patients understand, is that screening is your first weapon of choice. Right. Make sure you get screened often and early. Every year you should be screened. And that's what Ken was saying when he was saying about a mammogram, a diagnostic or definitely a screening mammogram for starters. Yeah, doing a monthly breast exam is great, but I don't depend on that. It's no different than I depend on just checking the prostate and thinking that's it. It is important that you guys, that ladies get down to that molecular level and we start screening. And we've been preaching that as primary care. I'm a primary care. Ken sees most of my patients, many of my patients for sure, whenever I have any issues with a breast, because he's an expert at it, and I yield to experts when it comes down to making sure that our women, ladies, are well taken care of.
So, Diane, I want to ask you, and Dr. Kane, I also want you to start first, Dr. Kane, and then Diane, I want you to follow up. Dr. Kane, do you need a referral for mammogram? And if so, does that have to come from the primary care physician, since that's what you are? And Diane, I would like for you to follow up with, do you get many women saying they would like to get a mammogram, but they can't afford it? So, Dr. Kane, I'm going to start with you first.
Technically speaking, no, you don't need a referral. But when it comes to the various insurance companies, they're, in the institutions that provide the mammogram, the hospitals or the standalone radiology networks, they are asking for referral because they're trying to make sure they get paid. I understand. That's how they keep the doors open and the lights on. So we understand that. But you don't need necessarily a referral. I'm not going to tell you to waste your time and just running up to, I'm not going to say waste your time, but I'm not going to say you need to run up to any of these places that take these mammograms and just say, I need a mammogram. I definitely want a physician. I would love for them to be involved because sometimes you get things back and you're trying to interpret what they mean. So you need to have someone who is somewhat of an expert in that field, i.e., when I say expert, just knowing something about mammograms, knowing something about breast cancer to help you move forward should the need arise.
Thank you. And Diane, do you find many women say, or any women who will tell you that I would like to get one, but I can't afford it? Diane? Uh-oh.
I think she may be frozen.
She's frozen. What about you, Dr. Jones or Dr. Kane? Do you find that many women? Go ahead, Diane.
Can you hear me now?
Yes.
Okay, so one of the important services that we do as a chapter in Jacksonville is to keep women informed as to where they can go to get a free or reduced cost mammogram. We've been doing that since our inception almost 30 years ago. And so we move throughout the community and actually even nationally to see where the financial resources are for someone who may need a mammogram or even services beyond the mammogram. So when we get those calls, and I have to tell you, it's not a lot, but when we get calls, we provide a resource list of what's available in the community. Of course, sometimes they have to meet eligibility requirements, but there are a lot of opportunities out there to get a free or reduced cost mammogram for someone who is uninsured or underinsured. And we keep that information handy because, yes, occasionally women come and say, I can't afford a mammogram, I can't afford my copay even. But I understand now that if they're insured, they should not have to pay anything if they're insured. But for women who are not insured or underinsured, there are means out there to obtain a mammogram. The physician does have to refer. Someone has to be able to receive the results. That's the only thing, and we've never had a problem with that.
And that's usually the big problem, somebody being able to receive the result.
Gotcha. So Diane, do you find that, or what would you say to a woman who, Dr. Jones already talked about how early a woman should start getting a mammogram. What would you say to someone who's been hesitant, and maybe it's fear because they've had a family history of breast cancer and they just don't want to know, or just think, oh, that's the other person, I don't have to worry about that?
It is ironic that you even mentioned that, because listening to Dr. Jones and now listening to your question, I want to at least let the community know that one of our projects this year when it comes to raising awareness in the community is to make sure that our young Black women are informed, that they are empowered with the information they need to take charge of their breast health. And so we tell them that, here's what you need to know, and it's going to be appropriate for their age, because not every young woman, well, first of all, they're not going to qualify for a mammogram, but by the time they're 25, they need to at least have a risk assessment. They need to know about family history. And, bottom line is they need to know that this is a disease that is survivable if it is caught early. So that would be the main thing that I would tell anyone who is frightful, who is fearful, who may have seen or lost a family member. Our best weapon right now is to attack it when it's early. Early detection, as they say, is our best protection. And that's what we talk about. And the other thing I wanted to add is when Dr. Jones was talking about the the younger women being diagnosed. Our topic this year, we're going to do 6 months of the same topic so that we're reaching as many younger Black women as possible. But our women can't wait until they reach the age of 40 for a baseline mammogram, because Black women are being diagnosed a lot sooner with aggressive forms of the disease. So we want them to know early on that they're at risk, and what they need to be doing, so that if they're going to be diagnosed, they will be able to be screened and detected early and treated early, and they can survive.
Dr. Jones, because I didn't want young Black women to think that it's a disease of older women.
Well, that's how we start the conversation. It is not a disease of an older woman. And if you're a woman and you're getting older, you're at risk. If you have breasts, I'll say that right, you're at risk. Now, the risk gets greater as you get older, but yes, our younger women are being diagnosed. And so Sisters Network, our chapter, decided that we need to piggyback on the message, for instance, that Dr. Jones has, and he's been telling us, and we thought, okay, now how can we convert his information? He's given us the medical information. He's telling us what's going on. And so we say now, as a chapter who's out here disseminating information, how can we piggyback on that and make sure it's getting to the populations in our community that need it? We do target certain communities where we know our mortality is highest, where we know where the disparities are greatest. And so we intentionally target those areas with our information.
Ken, what's the youngest patient you ever had with a breast cancer? You ever diagnosed
with a breast cancer diagnosis? 29. 29.
Actually, I saw a 19-year-old. I got one.
I wouldn't be surprised. And that is something that we should let people understand. There are many areas where a patient or a person could be considered higher risk. And we should know, if your mother had breast cancer, if your mother and your sister had breast cancer, or if your grandmother, mother, and a sister had breast cancer, your probability of developing breast cancer is very high. So that person is one that needs to have early screening because it's in your family. If you are a lady who has never had children, you're also at a higher risk. If you're a lady who has taken long-term estrogen replacement, right, you're at a higher risk. So those are some of the things that we know about, that we can understand that okay, I'm at risk. Don't let me ignore it until I feel something. Let me start getting my mammograms and my tomosynthesis. If I have very dense breasts. That's one of the people, those are some of the people that we're always concerned about. And we will order an MRI of the breast and then have to fight with the insurance company that they will pay for it.
Truly.
Okay, why we're ordering that. So that is so important. And one of the things that I think that has bothered me over these years is the younger African-American women with triple negative breast cancer. Now, for people listening out there, you have breast cancers that are estrogen receptor sensitive, progesterone receptor sensitive, and they're this thing called HER2, human epidermoid growth factor inhibitor, that's expressed. Well, most African-American women are ER negative, PR negative, HER2 negative, triple negative disease. Higher risk of mortality with that disease if you have it. It needs chemotherapy many times before and after surgery, and maybe we don't know. So what we're starting to do is African-American women who have triple negative disease, we need to start taking some of that tissue and do genomic profiling on it. What is it about the African-American diaspora that puts you at a higher risk of triple negative disease. And maybe we need to rethink how we treat this disease. But the only way that is going to happen is putting research money and looking at this population. And the way things are now with money leaving the NIH, I don't know where that's going. But we still have to understand in America, about 42,170 ladies die every year of breast cancer. And we diagnose invasive breast cancer over 300,000 patients. And then the early stage of breast cancer, which is ductal carcinoma in situ, that group, about 60,000 people a year have that diagnosis.
Yeah.
So it comes out in different areas that we have this disease process that's in our community. But the question is, okay, if we identify it early enough, what's our probability that we would stay ahead of it? Great thing if we can do that, but not wait till you come in and there's something the size of a baseball, and you ask, well, what's been happening here? Well, I just got big and I just thought it would go away. Well, that's where Sisters Network comes in, work in the community and understanding that's not normal. And then also taking the fear away that if the diagnosis comes back of breast cancer, oh my Lord, I'm dead right away. No, that's not possible. And some people require, and I mentioned earlier about genetic testing. Their number, next generation genetic sequencing will tell you about all these other genetic abnormalities that put you at an increased risk of breast cancer. And once they have been fully vetted, then those ladies may require a prophylactic mastectomy on one side if they develop breast cancer on the other side.
Prophylactic
Dr. Jones, I'm sorry, Dr. Kane, I got to ask this. Dr. Jones, I was just about to ask you when you were talking about genetic testing. Are you talking about the BRCA1 and 2?
BRCA1, 2, check. We have PAL-B. We have a whole bunch of tests now that will put you at an increased risk.
Do you have to refer, or Dr. Kane have to refer you to get genetic testing?
Usually a lot of the oncologists order it, but if a lady's at high risk, where mom, grandma, sister with it, you get the test.
Then when I heard you say something, Ken, I want to make sure people understand. But because some people hear the word negative and think that means you don't have it. So when you hit triple negative, that should not give you a level of comfort.
No, absolutely not. Absolutely
give you a level of discomfort.
That's right. It should give you a level of discomfort. For instance, if you have a lady, say you've gone through the testing, and this young lady comes back and she's BRCA1 positive. She doesn't have breast cancer yet. She's BRCA1 positive. She has a 72% lifetime risk of developing breast cancer. If she's BRCA2, it's about a 69% chance that she will develop breast cancer during her lifetime.
And don't forget, BRCA means genetic is done as a result of genetic testing.
Genetic testing, yes.
Right.
So that has to be important that the person get, and it's based on history, of course. Now,
what do you do then, Dr. Jones? If you get a 69 or 70-something%, what do you do? Just tell them, take them, just get rid of them. I mean,
that's what a lot of people do. And remember, these are the same people that get ovarian and uterine cancers. So after they've reached childbearing age, many of them age 40, if you haven't developed breast cancer, they get prophylactic bilateral mastectomies where you take the breast off and also do a hysterectomy and take out the ovaries at the same time in tubes.
That's a lot of women running in a different direction. That makes a lot of women running away from getting the diagnosis, but sticking your head in the sand. I just want to remind people, sticking your head in the sand does not mean it will go away. Okay, you might as well face it up front, and they're tough decisions to make. It'll be no different than I guess somebody told me I had to remove both testicles for whatever reason. You have to face those decisions up front. I just don't want them ladies to think that, again, I can hide and the disease won't occur. The disease is not hiding, it's there. You just got to go find it.
It's already there. And you know what's an important component of this is the spouse or significant other. Because a lot of women feel if I lose my breast, I'm no longer a woman.
I'm no longer
So
trying.
let me tell you, the plastic surgeons can do a wonderful job today.
Yep.
I mean, you don't have to have implants. We can do deep inferior epigastric perforator where they take the tissue from your abdomen and put it up there. It feels like normal breast tissue. And so
And you get a flat stomach. I'm sorry. I
you get yes, you get a very flat stomach with it. But at the same time, I think that many ladies feel, and I've had patients, honestly, who have come in, I've explained to them based on the size of your tumor and the aggressiveness of your tumor, your best option would be a mastectomy with reconstruction. But their boyfriends or significant others like, oh, well, we don't want the breast removed. Well, do you want the whole lady or you want a breast? And
Yeah.
if you don't do the breast, and do the appropriate surgery, you're cutting her lifespan. So
Yeah.
you prefer to live your life without her, with reconstructed breasts, or dead soon with real breasts?
Now he'll be her last boyfriend one day, okay? Because she sits back and she died from breast cancer. That's the last boyfriend you ever had.
That's
Okay,
right.
So
You know
we're gonna pause for the mid-show moment. Don't go
Let me
anywhere.
say one last thing, Ms. Turner, before you get off. One other group that we need to be aware of is those women whose father had prostate cancer, and we didn't touch on that, but prostate cancer in your dad or brother is a high risk, put you in a high risk category.
And remember, 1% of all breast cancers occur in men.
Yeah.
Well, men who have mothers and grandmothers and sisters with breast cancer are at higher risk also.
I didn't want to lose that thought.
Yeah, I was actually going to bring that up after the break, but thank you, Mr. Kane. So Tyrone, if you could take it away for the mid-show moment, and we'll be right back to our audience and to our guests.
Today is October 21st, 2025. Welcome to Pause for the Truth Mid-Show Minute. Let's talk about a truth that doesn't get said enough. Breast cancer hits the African American community harder, especially black women in the U.S. Even when overall incidence is similar, mortality is about 40% higher. That gap isn't random. Here's why. First, biology. Aggressive subtypes like triple-negative breast cancer show up more often, grow faster, and don't respond to common hormone therapies. Second, earlier onset. Diagnoses often happen younger, which means screening needs to start earlier and be more intentional. Third, later stage at diagnosis. Larger tumors are found more often, tied to access, delays, and trust gaps. Fourth, genetics. Some families carry higher risk mutations like BRCA1. If that's your story or you're unsure, genetic counseling can be game-changing. And fifth, the system. Insurance hurdles. Fewer nearby specialists, implicit bias, time off work, transport, and a very real history of medical harm that fuels mistrust. Globally, places with universal healthcare often see smaller gaps between groups. Disparities still exist, but not at the scale we see here. The U.S. has incredible treatments, yet access can depend on race, income, and postcode. That's the uncomfortable mirror. Imagine two paths, one well-lit, easy screening, quick follow-up, timely treatment. The other overgrown, late appointments, confusion, and delays. The outcomes diverge long before the first infusion starts. 1. Early detection is everything. The earlier it's found, the better the odds. 2. Know your risks. Family, history, genetics, lifestyle. Bring them to your doctor. 3. Screen regularly. Ask if earlier or more frequent mammograms make sense for you. 4. Know you're normal. Any new lump, change in skin, nipple discharge or trough, or en bursuri kinbatsas panimberdian, en skirindikes, statscancer en quats en british, faringosendegar, 5 viberzon. Remember, not all breast cancers are the same. Understand your specific type and stage. If you're newly diagnosed, first steps. 6. Get a second opinion, especially for aggressive types. 7. Build your team. medical oncologist, surgeon, radiation oncologist, and a genetic counselor if indicated. 8. Ask clear questions. Type, stage, options, side effects, timelines. Take notes or bring someone. 9. Explore clinical trials. Vital for triple negative and other high-risk cancers. 10. Build support. Family, friends, faith, culturally specific groups, and mental health care. Here's the takeaway. Disparities are real, but knowledge plus action saves lives. Advocate for yourself. Ask sooner. Screen sooner. Push for clarity. And if the path in front of you looks overgrown, you still deserve the well-lit route. This has been Pause for the Truth Mid-Show Minute. Stay informed. Stay seen. Stay alive.
So Diane, I want to ask you, you've talked and praised Dr. Jones a lot for his support over the years, but what would you say, or what message what would you say to healthcare providers to help them better understand about supporting patients emotionally and culturally? Have you heard women talk about, I wish my physician was, more supportive, listen, talk? Is there anything in particular that has resonated or has come out more? And I ask that question because we have physicians who are listening to the podcast.
So while I might not be able to address that directly, what I can tell you is my experience since joining Sisters Network almost 30 years ago to today. I can tell you that 30 years ago, 20 years ago, even 15 years ago, the doctors were not as attentive as they are now to our needs, our specific needs. And our membership can talk to that. In fact, they do often. They talk about the difference in having gone in 20 years ago for a procedure and being numb, not having any information, and pretty much just following what the doctor advised. However, now we're talking about a new group of people, a new generation, and we're helping as Sisters Network. We're helping these ladies to arm themselves with the information before they go in. And we have taught a workshop in the past that dealt with just specifically talking with your doctor about your breast health. And the information could have pertained to any condition, but we specifically gave them questions to ask. We gave them tidbits. We had little scenarios where they play acted, how they would address problems, how they would talk. And then we gave them some reputable websites to go to. I mean, I don't advocate people going out to any website to get information and follow it, but we advocate going to the reputable ones to look up information so that they can develop questions. And I can tell you that in my own experience from before till now, I go in with questions and my doctors are ready to answer those questions, and they are not taken aback by the fact that I come in with a list and a pencil and a pen. And this is what we advocate for our women right now. We didn't have that years ago. Maybe Dr. Jones can talk to whether or not our physicians' training has changed. I think that it has. I think they're now being trained to be more receptive to the opinion of the patient.
Thank you, Diane. And go ahead, Dr. Jones.
What we're seeing in the training is that part of the training, we discuss what's called cultural competency. Now that's just disappearing under this new situation we're on. But part of how we trained people is we would teach them about cultural competency and then give them a little test to see if they understand, give them different scenarios where when you come in a white coat and you're Caucasian and you're looking at an African-American woman and all she's thinking about, she sees you and she remembers the Tuskegee experiment. So when you ask her about participating in a study, it's like right away they put up a wall. But what we have found is when we put African-American intermediaries, the patient feels more comfortable, and then they would participate. So a lot of the big studies go on in these big institutions that have no Black people around. And they're trying to get African Americans to participate. Well, that's not an easy task to do, because no matter what you say, African Americans, a lot of them still have suspicion of the healthcare system when that care is not being delivered by someone who looks like them. And we have data upon data upon data to show that the outcomes are better when African American doctors deliver care to African Americans. That's because they feel comfortable. They don't talk down to them. You know, they're treated like a human being.
Absolutely.
Yeah, and we put up on the screen, we had the American, thank you, Dr. Jones and Diane. We had the American Cancer Society representatives on last year. We talked about the Voices of Black Women study, and I think it's a phenomenal long-term study to follow women between the ages of 25 and 55, to follow them along the way, to see what's been happening to them. Are there any environmental exposures? Dr. Jones, you've talked, just so much tonight about why Black women die more than other women. Well, this study could potentially say that. So you think about a study that can change, as this says, the future of cancer as we know it. So we had the American Cancer Society representatives on to really encourage ladies between 25 and 55 who've never been diagnosed with cancer to join the Voices of Black Women study. It doesn't cost you anything. All they want to do is know that you exist and hear about your life, the things that happened to you over your lifetime. Dr. Jones, I want to talk a little bit about treatment. So I had a friend, I'm not going to mention her name, especially because you were her surgeon. But I remember last year when she got a breast cancer diagnosis. And of course, other than, feeling her pain, I tell you, that woman, I hope she's listening, because she was the most positive in terms of her outcome, and knowing that I'm going to beat this, I'm going to be fine. She was referred to you, Dr. Jones, and I don't know if she was referred to you, but somebody told her you need to go to Dr. Jones. And that's what people do when they say, here's who you go to for your treatment. But we had Dr. Cobran on from Mayo Clinic talking about the prostate cancer study. And one of the things that he talked about as far as treatment goes is that you can do, what do you call it? Precision medicine, precision treatment. So is that also an option for breast cancer treatment when someone is diagnosed, precision medicine, to know specifically what treatment works best?
Well, that's why they do, next generation genetic sequencing, because we're now looking at, not every breast cancer benefits from chemotherapy. There are some breast cancers that you can treat with just hormonal therapy and or radiation. There's some cancers that are early stage that may not need radiation. So breast cancer treatment now is being very, very targeted so you don't bring all comers and say, well, we know this is what works, we'll give it to you. But we can do certain genetic testing. We have Mammoprint, Blueprint, we have Oncotype DX. All these tests are done to see, will chemotherapy make this person better, or it wouldn't have an effect. So they look at the genetics of the tumor. And if that tumor says, you know what, if they give this person chemo, it's not going to make a difference on their outcome. But if you give them immunotherapy, or if you give them hormonal therapy, it may provide a better outcome. So yes, it's a lot of targeted treatment. And one of the things that, we're seeing now is we're looking at what people are using, like the skin lighteners, the hair relaxers, acrylics on the nails. All those things have an effect. And they're now looking at that to see if the environment that a lot of African American women are in is that contributing with this? We're seeing all these younger African American women getting breast cancer. They're doing things to their hair and their body and all this new stuff that their grandmothers never did, maybe, or their moms didn't.
Yeah.
So it's still ongoing. We need to know, but there's certain things we know we should work on. Don't smoke, lose weight, that kind of stuff. I mean, but whether you have a baby or not, some people can get pregnant. But if that's the case, then you need earlier surveillance. You can't wait. If you're if you've never had a child, you can't wait like the other folks wait.
Yeah, I'm glad you mentioned about the relaxer and some of the products, because I remember a coworker told me, Dr. Jones, former coworker, told me years ago when her friend was diagnosed with breast cancer, that she was informed not to get her any relaxer during her treatment, especially. And so she was like, wait a minute, what do they know that I don't know? So she stopped getting a relaxer just to support her friend. She cut her hair down short, just kind of really being a support to her friend. But it just made her think like, oh my goodness. And I must admit, Dr. Jones, that's when I stopped getting a relaxer, right after having that conversation with her. And then as time has evolved, we hear more about the different products that we use on a regular basis. I hadn't heard about the acrylics. Guilty. So I gotta, that's another thing. Don't laugh at me, Dr. Kane. Another thing I gotta eliminate. And then when we were talking with our dietitian about a month or so ago, she was talking about the what was it, the charcoal from cooking. I'm just like, Jesus, all things that are in our community that is so prevalent in our community, we just don't know how much is hurting us. That's what I like about this podcast, Dr. Kane.
The charcoal was on barbecuing. That's a whole nother subject, man.
But just think of the hair relaxers. You think of all the chemicals. Those things have lye. They have, you name it, sodium hydroxide. They have all this stuff in there that you're putting in your hair that's seeping into your scalp. We don't know what it's going to do in the long term. Those are some of the things that, as African American females, that we should really think about the environment that we're in.
It reminds me back, remember now that it wasn't that long ago African American males was putting these relaxers and stuff in their hair back. and we would be in the same boat, but we started looking ridiculous, so we got out of it and stepped away from it. So I love the sisters who are sitting back and going with the natural look, because I think it keeps them healthier, to be quite frank with you, is my concern about that. The only other thing I'm going to say real quick was that when it comes down to research, we have to understand that many of our patients feel, as Ken said earlier, feel more comfortable if that research is led, or they're led into that research possibility by a physician that they trust. And most of the time they are trusting physicians that look like them, that look like their mama, their daddy, because when I see patients in my office, I think of my mama, sister, brother, son, daughter. That's who I look at. That's what I see in the patients that we treat. And I'm not the only one to do that. That's not just to me. That's to many of the Black physicians who are sitting back trying to make sure that their patients are well taken care of. And they do not mind overseeing anyone's participation into a research program. We're always looking at doing research, regardless of whatever the subject matter may be, in African Americans, because such little research has been done in the past to give us a heads up on what's best for us. And when it's directed by us, especially when we're overseeing it, I pay out, and I'm sure I get the idea from my patients that they too have a lot more confidence in participating in those clinical trials.
Thank you. Diane, I want to ask you, how has your experience being a breast cancer survivor changed your approach to self-care, faith, or advocacy?
Did you say self-care, faith, and advocacy?
Self-care, faith, and advocacy. Yeah.
Well, of course, self-care. I'm sure that I've made some changes after being diagnosed. I have to think twice sometimes about diet and exercise, but I have to admit that I was not obese, and I didn't fall into any category other than being a woman getting older. I had no family history. And of course, we didn't know enough about what causes breast cancer at the time. However, I am guilty of having used the hair products and the sculptured nails early in my life. But even now, I have to tell you that now I do consider what I'm eating, how much exercise I'm getting, because I know that, good exercise and maintaining a healthy weight, healthy diet, I know those are things to reduce risk, even though I've been diagnosed. As far as my faith, wow, I've got lots of stories to tell about faith. It would probably take another hour, but just to have come as far as I am, having been diagnosed so many years ago, having had a number of recurrences, and still I am cancer-free, I have to say that, while science matters, medicine matters, faith led me. Because I could have made some other turns, and I know that. And I could have taken some other advice, and I know that as well. So I'm thankful for where I am. I will always be thankful. I'm a believer that God puts people in place for you at the time that you need them. It may not remain, but I'm thankful for life. Now, the advocacy.
Before you move, can you share with people how many times you mentioned recurrence? I remember, but can you tell people how many recurrences you had?
It's unbelievable. So, in addition to my initial diagnosis in '87, I've had 5 recurrences. The last 2 were metastatic disease to the lung, and I have been cancer-free according to results and lots of scans and all for it'll be 20 years in February. Now, I'm going to add to that. I'm thankful, I'm happy, I'm joyous, and I continue to live what I believe is a good life. But it doesn't mean that I don't think about my diagnosis almost daily.
Certainly.
I think about breast cancer, I think about recurrence, but I try not to let that overpower me. And so a lot of years ago, I decided to learn as much as I could to help myself so that I could have a level of comfort, whether I was going to succumb to the disease or survive it. I needed a level of comfort, and I needed that knowledge. However, I decided that what I was learning for myself was eye-opening, and if anyone else would benefit the way that I did, I wanted to be able to share it, which led me to advocacy. This led me to establish this chapter of Sisters Network, so that what I was learning, if it was benefiting me, surely another woman could learn and benefit. And that's where I am today, just still trying to make sure that whatever the information is, I'm not holding it to myself.
How can other survivors become advocates in the community? Can they get involved with your organization? And if so, how do they do that?
So if they're interested in getting involved with this organization, absolutely. We welcome our non-survivors. We have a lot of what we call our advocates and our associate members who want to be a part of the group so that they too can help a survivor, can support a survivor, can go into the community, can speak on our behalf, can help just to help us with our programming. And the way that they can get in touch with us, there are a couple of ways, but the easiest way for this podcast is for me just to give the telephone number, don't you think?
Yes,
So
that's fine.
the phone number to the office is 904-757-6622. I did not mention this earlier, but we are a 501c3 organization, charitable organization. We're all volunteers. We have no paid staff. We're not all survivors, but the majority of our membership are breast cancer survivors. And some of our members are family members and caregivers and just people who want to be a part of what we do. So we welcome anyone from any walk of life who has a level of expertise or even a desire, and they're motivated to assist us in these programs in the community. We welcome.
Thank you. Dr. Jones, what gives you hope for the next generation of women when it comes to breast cancer prevention and treatment?
I think we're becoming very specific. We're doing a lot of genetic sequencing. We're getting the information out via organizations like Sisters Network for early detection. We've got to remember, if we find this disease early, I have patients I operated on in 1983, early disease, who are still alive today with no evidence of recurrence. But it was early stage disease. Because we have to remember recurrence after treatment. Say you've got breast cancer. In the numbers are like in 10 years, your probability of recurrence is somewhere between 19.3%. 15 years, it's about 21.4%. So the longer you survive after, the probability of recurrence. And many ladies ask, okay, you've done one breast. What's the chance it'll come in the other breast? It's 0.5 to 1% per year that you could get disease in the other breast. So from my perspective is first doing the appropriate calculating risk calculation, which is something every young African-American woman from age 25 should have. Of course, a lot of that is not in our quality metrics. And by that, I mean, in everybody's practice, their quality metrics. Who should have a colonoscopy by what age? Which diabetic should have a retinal exam? I think part of the quality metric should be African-American females age 25 and over should have a risk assessment calculation based on the Black Women's Health Study. That's a different one from Gail and Tyra Cusick. That's totally different. In that younger, and if at 25, 26, you get that and it shows you're a high risk, that's when you have to do more frequent evaluations. And if you see something that you can't figure out, you get a biopsy. Now, we didn't talk about the diagnosis. If we see something that looks suspicious, we then send you or the person for what's called an ultrasound guided diagnosis. And they do take a needle and they get some of the tissue to see whether that is invasive cancer, early stage ductal carcinoma in situ, lobular carcinoma, atypia, papillary tumors, atypical duct hyperplasia. When you get that diagnosis, all of those we do biopsies. When you see that, the plan is to remove it all. Not a mastectomy or anything like that, if it's very small, but to get it out. And going forward, not everyone will need chemotherapy. Not everyone will need radiation therapy. Not everyone, there's new data to show that we can do ultrasound, high frequency ultrasound, destroy the tumor in the breast. But then we don't know what's left because we live in an environment now that when you take out a breast tumor, they want to know how far away from normal tissue it is. So there's a lot going on, but it's imperative that African-American females get included in breast cancer research, either by tissue to see what it is that's so unique about the genetic makeup of the tissue of the African-American diaspora that puts her at an increased risk of mortality from a disease, even though her incidence is not as high, her death rate is higher. And that's what we need to know.
Yeah, and I'm glad you said that, Dr. Jones. And you know, the last time we had you on, we had a young lady on. She was in her the early 30s when she was diagnosed. And out of respect for her family, I don't know if they want me to mention her name, but she was such a warrior and really living her life. And unfortunately, she didn't make it. And it was a very sad day because she was a young mother and when she was diagnosed, and young lady when she passed. And you know, that was a sad day. So I'm glad we're having this conversation, and I just encourage people. And the only question that I have left of you all is to say that, you know, Dr. Jones, when you go in and you get the test, but you're told, well, you know, you get a biopsy and it says, well, you're okay for now, but come back every 6 months. Like, what are you waiting for me to get it, or what? I mean, like, come on now, what in the world?
That is something that we're trying to avoid, is that if it's suspicious enough to see it again in 6 months, send them, get a core biopsy of it, and let that person not worry. I've seen so many patients who've had 2 and 3 of those, and then a year later, the fourth one shows cancer. Remember, you can't get every spot in that if you do the biopsy. But if the biopsy is in any way suspicious, you say, you know what, let's get this thing completely out. And, you know, remember, women get breast cancer while pregnant also. So anything significantly abnormal in your breast exam during your pregnancy, get it evaluated. We've got to be very cognizant of that. Don't think, oh, it's a milk gland and it's getting bigger and it's going to go away. Because, you know, in my practice right now, I think I have 3 people with that who are like, you know, one actively pregnant, one, you know, all of them. So that becomes a very unique situation. Where do you give this person chemotherapy, and when do you start it? After the second trimester, you can. And, you know, people in their second trimesters get it. But again, an abnormal examination during pregnancy is not normal. An abnormal exam is not normal. Make your physician aware of it and let them know you're concerned, is it breast cancer, so that they can do additional testing. So pregnant ladies do get breast cancer. So we must remember that.
Dr. Jones, I think you're speaking very well to the ladies in the audience, but you're also speaking to those clinicians who take care of those ladies in the audience, for them to make sure they do not forget that just because they're pregnant, they will not have breast cancer.
That's right.
They aware of that, and you and I have to be aware of that. So that's for those clinicians in the audience that are listening.
Thank you. Well, we've reached the end of the hour, and as Dr. Jones said, we didn't talk a lot about once you get the diagnosis. So that means hint, he has to come back. But thank you, Diane and Dr. Jones. At the end of every hour, we like to give our guests an opportunity to share their final thoughts. Diane, I'm going to start with you. Please share your final thoughts on tonight's topic.
Well, I think you've covered just about everything that involves Sisters Network from our viewpoint, as far as you know, our activities and what we believe, and we'll just continue to work in the community as long as we're needed. And the way we see it, until there's a cure or some kind of prevention, we will be needed, and we'll be there. I just thank you for the opportunity to share this information and to let the community know that we're out there, and we will continue to do this work with their support.
And we'll definitely make this video available for you to share with your members, and even as you do presentations in the community. So thank you, Diane. Dr. Jones, what are your final thoughts regarding tonight's topic?
Well, it is so important, but the most important for me is early detection. And if you're diagnosed, be able to contact an institution like Sisters Network to talk to women who have actually gone through what you're about to go through. because I do not care. I mean, unless the doctor had breast cancer, you cannot explain that to anybody. But someone who has actually been on the medication, who's lost their hair, who's got the numbness in their fingers, who are losing their nails, they can have that conversation with someone who's gone through. So we do the medical stuff. I'm happy Sisters Network is here to do the real hard work, which that is the hard work, keeping women's spirits up. But early detection continues to be my goal, and getting African American ladies, their tissue at least, in research to find out what it is about our tissue that puts our young ladies and our mothers and sisters and grandmothers at an increased risk of dying when they develop breast cancer.
Thank you, Dr. Jones. And Dr. Kane, what are your final thoughts regarding tonight's topic?
Yeah, I got to comment on something that Ken said. You know, those ladies that are losing their nails, let's lose them before you get breast cancer. Stop putting those fake nails on, and so that you don't get exposed to those chemicals that may be increasing your risk of breast cancer and then other kinds of cancer. Ms. Townsend, I just wanted to thank you for your brave lady. We really appreciate what you've done for this community just by starting this network. I want you to keep up the good work. You know, I wish the even greater success in what you guys are doing locally, and we need you guys even now more than ever because of all the ongoing political crap that we're looking at these days.
That's true.
That's a subject for a whole nother podcast. So, but we really appreciate you guys, the kind of work you're doing. You know, you guys are, even though you're not medically trained, just being who you are and what you've experienced means a lot to our community, and the guidance that you can impart to those ladies who may go through what you're going through or what you have been through is excellent, and I hope you guys never give up. Okay, regardless of what happened with the administration and the politics of this country. Dr. Jones, a similar thing to you. You know, you've been my friend for many, many, many years. I hate to see your retirement because of all the knowledge that you have. I don't know what I'm gonna do. I'm gonna try to figure out something. I'm gonna still tag you when I need to because you're such a gem to the knowledge in this community, both laymen and those professionals, the physicians and yada, 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 the clinicians, and so on and so on. The one thing that I want people to remember, just because you get breast cancer does not mean it's an automatic death sentence. There is treatment out there for you. But the earlier we can seek that treatment, the better off you, the greater the chance of survival you and your loved ones have, because whatever it is that you wind up having, you know, it makes a difference to your offspring, your sisters, your offspring, your kids, your sisters, you know, and maybe even your mom, because there's nothing written in stone to say she'll get breast cancer before you. So keep all that in mind. Thank you guys very much for coming on to the podcast. It's not enough time, but we will bring you back.
Thank you.
Thank you, Dr. Kane. Tonight's conversation reminded us that breast cancer is more than a diagnosis. It's a deeply personal journey that affects our families, our communities, and our future generations. We've learned that while African American women may face a higher risk and later diagnosis, we also have the power to change that story through awareness, advocacy, and sisterhood. Thank you, Dr. Kenneth Jones, for sharing your medical expertise and helping us understand the importance of early detection and compassionate care. And thank you, Miss Diane Townsend, for your courage and for showing us the strength that comes from community and connection through the Sisters Network. To our listeners, get screened, encourage a loved one to do the same, and support organizations making a difference in the fight against breast cancer. Visit pauseforthetruth.com to replay this episode and to learn more about future conversations that educate, empower, and uplift. I'm Jocelyn Turner, and on behalf of my co-host, Dr. Rogers Kane, and our behind the scene technical expert, Tyrone Jackson, thank you for tuning in to Pause for the Truth, where we speak truth, build health, and strengthen our community. Until next time, take care of yourselves and each other. Good evening.
We appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.